I'd like to bring in what we have seen as far as the treatment has evolved in the past few years. What are the challenges that we had in the country and in Tata Hospital, and how COVID has actually helped us look at this from a different perspective, taking it ahead. Now, we all know about COVID, and we know that it is a single-stranded RNA. What is peculiar about this is that it enters via the mucous membrane of the nose, oral cavity, and eyes, and it remains harbored in the nasopharynx and oropharynx for the first few days. And that's where it becomes critical to avoid the aerosolization. Thereafter, it progresses to the lower respiratory tract and then causes all the immune-mediated damages. So we have had a lengthy course of COVID in the country, over 99 lakh people affected. But what is heartening is that the case fatality rate is 1.5%. Now, COVID-19 and cancer, what seems to be the connection? What is it that actually makes us think about COVID and cancer in the same breath? We need to understand that the patients of cancer are at highest risk for getting COVID. Why? Because they need to actually come to the hospital. They require multiple visits. They are come in contact with a lot of people and they get examined at close quarters. And this is also making their systems immunosuppressed by the treatment of malignancy as well as by the cancer itself. When you look at the data that comes in from various countries, especially China, which had the unfortunate largest cancer, the COVID infection earlier, they found that there was significantly higher risk of COVID compared to community, almost 2.31 times odds ratio. We also know that cancer patients are more likely to have severe complications. When they reviewed over 72,000 cases of COVID, they found that the case fatality rate for cancer patients was 5.6% compared to 2.3% for the overall population. So there is something going on as far as cancer is concerned when you get COVID. Now, COVID and head neck cancer, head neck surgeons in particular, we know that the COVID spreads by human to human transmission by droplets arising from the upper aerodigestive tract. The aerosol genetic procedures of head neck and ENT are caused by the instrumentation of the upper aerodigestive tract. And remember, this is where the virus harbors for the first few days. And ENT and head neck surgeons come in frequent contact because we are examining all these areas with the flexible scope, the nasopharyngeal scope. We are doing oral examination. And we are doing procedures which actually cause this aerosol generation. And that is why head and neck treatment is at the highest risk, and the head neck surgeons are at the highest risk for contracting this disease. Now, when you looked at COVID-19, the first thing was postpone all the cases. You heard the dean say that the world over, people said, let's postpone elective surgery. Let's go look at how we can reduce contact of people with the patients. But what is important to realize is that when you postpone a cancer treatment, it has to be weighed against the potential morbidity associated with its delay. Head and neck cancers in particular, they get upstaged and they progress when the time to initiation of treatment increases. We know from our data that more than 6 weeks of delay increases the tumor size by almost 30%. And this may increase the mortality and also, if cured, can increase the possibility of recurrence. All this notwithstanding, if you tell a patient, I'm going to delay your treatment and he knows he has cancer, this unduly causes a lot of anxiety to the patient. And he knows that nothing is being done because we are worried about COVID. So various triages were brought about in literature, and only the urgent cases, the ones that could not wait, were allowed to be treated. So in cancer, the ones that were urgent, so when you look at head and neck cancers, the ones that were anaplastic cancer, thyroid, the ones that had melanomas, ones that were having multiple nodes, those were urgent cases. Unfortunately, you had a benign lesion. You were back on the back burner for more than 6 months. Various triaging processes were developed, and in head and neck, we had to have a triaging where a group of doctors would then decide whether the treatment was urgent or not. And if it was not urgent, it was delayed and put on a back burner. Now, at Tata Hospital, what did we do? Jan 30th, the first COVID case came into Kerala. The student came in from Wuhan. And Mumbai just began to see these cases by March. By the second week of March, our team at Tata Hospital, the administration got its act together. They actually formed a COVID-19 action group as a command center. It was constituted by clinicians, paramedics, nurses, and hospital administration. And as the dean may be aware, our anesthetists had a leading role in this. They manage our intensive care units, and they were the backbone of our COVID-19 action group. They were regular interactions, and it was like a war room concept. Daily interaction, daily discussions. No one knew much about COVID. No one knew what was going to happen. And daily interaction was done, and work was done on multiple fronts simultaneously to cover all eventualities. The bottom line was to ensure free and transparent communication. And that was very important. So we did on various fronts. We did employee education and training, staff health and safety, the patient education and awareness, containing crowds, triaging the patients, having a hospital preparedness, trying to address the supply chain disruption, and then meeting staff requirements to continue optimal patient care. Besides this, Tata Hospital also decided to have sharing information because we were part of the National Cancer Grid, and this, our experience, could help other centers as well. So what employee-directed initiatives did we do? First thing we started was employee education and training. A lot of myths and fake news were strife at that time, and it was incumbent on us to prevent these. The staff medical records were analyzed, and those with morbidities, more than 50 years of age, those who were pregnant women, they were given full paid leave with option to work from home. The staff was rotated. We ensured that all the staff, right from with the level 4 to the top, was rotated. And this was to create a reserve force. We wanted to avoid fewer exposures to potential infection, avoid overcrowding in the hospital, and reserve some staff in case of a mass quarantine. As far as the patients were concerned, the most important thing was to create awareness. We had prominent posters put up in the hospital. We had mass text messages being sent out to those with routine appointments, advising them to postpone the visits. And we had developed the screening camp set outside the hospital. What we realized was the hospital was sacrosanct. We could not allow the patients who were infected to come in. So we decided to screen them outside the hospital. So in these screening camps, patients who were required to be seen were triaged by doctors from different respective disease management group. In Tata Hospital, we form a disease management group as per the site. So the head and neck disease management group comprises of the surgeons, the medical oncologists, radiation oncologists, the speech therapists, pathologists, and radiologists. So all these formed a disease management group. So the doctors would triage the patients who were seen outside, and only if they actually required some procedure would they be let into the hospital. The outpatient clinics were manned by doctors with senior consultants, providing on-the-spot decisions to avoid crowding. We normally have every patient go through a joint clinic, that's a tumor board, and we had multiple meetings done during the day in order to disperse the patients and avoid overcrowding. Believe me, it was an Herculean task to screen up to 3,000 patients per day at the hospital gate. But all this reduced the crowds within the hospital by 1/3. By end of the first week, we found this was not really going to be very beneficial in the long run. And we decided to change our approach and try to contact the patients directly. So the respective DNG doctors would personally call every patient who was due for appointment the next 2 weeks and then try and figure out whether this patient required to come. So what happened was this actually helped us reduce it by another 50%. And what was more important, the patients were greatly comforted that they were actually talking to a doctor who was spending time and trying to understand what was their problem. Besides this, we modified our evidence-based practice that we have, our protocols. We deferred case surgeries whose outcomes would not be grossly inferior by postponing them. We modified our chemotherapy regimens to minimize the chances of developing complications. We avoided having some chemotherapy protocols which did not have any substantial survival benefit. And as far as radiation protocols, we decided to minimize treatment duration. So trying to increase the output per patient per machine. The hospital preparedness was really difficult because we didn't know what to do. What would happen with patients who come from abroad? What do you do with a patient who was unwell but without any cancer? Would he be shifted to a hospital? Would we have to shift to another hospital? All these were issues which were handled day to day. But what was important was we decided not to be a general COVID center. We decided that cancer is an important and emergent situation and is as important as COVID. So we decided to continue as a cancer treating hospital rather than a COVID treatment center. We formed a clinical group which was constituting members from the hospital infection committee, and they conducted mock drills. Believe me, the mock drills was the most important thing that helped us. The management in the operating room, in the COVID theaters, we decided to have 3 operating rooms which are designed for COVID so that we have the negative pressure system in them so that we could dissipate the air and not get it circulated within. We also got approval within a month for the COVID-19 RT-PCR testing from ICMR, and this greatly reduced the uncertainty of the tests available outside, as well as we were getting reports within 8 hours. Our team worked round the clock, our molecular pathologists and the biochemists were ensuring that we got the reports within 8 hours, which was amazing. We developed a fever OPD where the patients who would have fever were seen. So because we had one area where all these patients were contained, the use of PPEs and all was reduced greatly rather than have it all across the hospital. And this actually helped us plan out very securely which patient would travel into the hospital. Now, the impact and handling of a nationwide lockdown was something we couldn't manage. Immediately, our patients were affected because they could no longer travel. No longer they could come here. And those who were in the city were stuck because they could not leave. So the patients who were here, their relatives, they were falling short of money. The food was getting over. And these were things that our administration dealt with very swiftly and efficiently. We realized early on that we were falling short of all these basic amenities like the masks, the N95, the PPEs, and we got a lot of funding from CSR at short notice. The various groups like the Tata Sons and all, they came forward and brought us a lot of equipment, and we ensured that we had the entire stock which lasted during our required ordeals. There were certain last mile supply issues, but then we would send the staff vehicles to those companies in order to get all these materials. Now, the most important thing was the National Cancer Grid. And as you all are aware, this is a collaborative effort set up by the Tata Hospital, where more than 200 centers, cancer centers in the country are collaborating. And what we underwent, what lessons we learned were quickly disseminated every week on these webinars, which were conducted in the NCG. They also now developed the NCG guidelines for management of cancer during the COVID-19, which helped a lot of centers which were not having or not geared up for COVID. Now, where TMH succeeded, I feel it was a combination of systematic strategizing, an environment permitting healthy disagreements, rapid multi-pronged implementation, the willingness to modify decisions at short notice, effective communication both with patients and employees, and above all, unstinting cooperation and teamwork, which was key to overcoming unique challenges. Now, surgery in particular, owing to high infectivity and alarming increase in number of cases, most hospitals in our vicinity decreased or altogether stopped elective interventions, especially head and neck cancers. Now, ambulatory visits were curtailed, wards and operating rooms were emptied, and the ventilators were commandeered for COVID-19 patients. Now, remember that head and neck cancer burden is almost 2 lakh new cases each year, which is 1/3 of the cancer burden in the country. And when you go to see 60 to 80% of patients present with advanced disease which require multidisciplinary care. So what did we do? We decided to continue the elective treatment of cancer during this period. But we didn't go this pathway unprepared. What we realized was that we needed to triage out. Early on, we didn't have the testing available, and we went only by symptoms. So from March 23 to April 30, we performed about 520 surgeries. 494 were elective surgeries, whereas 26 were emergency. When you can see that 36% were residents of Mumbai and 63 were outside Mumbai and Maharashtra. Almost 85% of these were high-grade surgeries. Head and neck surgeries formed almost 17.6% of these group. If you look at the morbidity, we had a 5.6% morbidity and there were no deaths. There were 6 cases that were tested positive. Later half of April, we started doing the testing. And 6 patients were tested positive. You can see half of them were head and neck cancers, but none of them died and none of them required any escalation or intensive care treatment. You can see the head and neck cancers, almost 54% of these were grade 4 and 6 cancers. And none of these had any morbidity or significant complications. So our low rates of major complication and zero mortality reflects the COVID-19 centric policy of our institution. And what is important is that the philosophy that regardless of COVID-19, cancer centers and specialists are available to take care of their patients. And this is what message we wanted to give the world, that this is important to continue your care because cancer is equally important. Now, this brought us to think about and reflect on what we were grappling with at Tata Hospital before COVID. Now, this is our OPDs and this is how we had our OPDs and forever. And we were trying to understand how to reduce this. So when we did an audit and it was published early in this year, and this was trying to analyze what was it that we could do to change this OPD overload and treatment overload in our sector. So going back to 2015, we realized that we still had a lot of head neck cancer in the burden in the country. 80% of outpatient and 40% of inpatient in India are provided by private hospitals. And however, relatively higher number of patients diagnosed or suspected with cancer present to government hospitals. But due to lack of referral system in India, combined with the paucity of tertiary care cancer hospitals, these centers cater to a high volume of patients. So when we looked at our data, we realized that most of our patients are coming from outside Mumbai and outside Maharashtra. So 80% of the patients coming from outside Mumbai. Almost 53% of our patients, head and neck cancer patients, had oral cancers, and 80% in stages 3 and 4. When we did the tumor board evaluation, we found that 24% do not come to the joint clinic. So by the time they just come, register, and then they go away. And 85% actually require curative treatment. So if I register 100 patients, 85 of them will require a curative treatment. That means I have to provide for 85 patients. 51% require surgery, and we could cater to only 50% of them. Amongst those that had required non-surgical treatment, only 1/3 of them could be treated at Tata Hospital. So when we looked at all the resources required for surgery and radiation and chemotherapy, in 2015 we realized we required twice the number of resources for surgery and 3 times for radiation and chemotherapy. So this was not possible. You can't suddenly increase your infrastructure over the years. And with a 4% increase in the number of patients registering with us each year on year, we realize that decentralization is required at a national level. Patients require the right treatment closer to their home, and this will not only improve the compliance, it will be very cost effective. So what is the need of the hour? The need of the hour is decentralization and early treatment decision and early referral. And this is only happens when you have increased number of trained oncologists in different regions of the country, which makes decentralization feasible and ensures quality of treatment. So now coming back to what we did thereafter, we wanted to know, can a telephone call detect recurrence? Can you talk to a patient and understand whether he has a disease coming back? Because that is the most important reason why a patient is kept for follow-up for 5 years. So we analyzed around 400 treated oral cancer patients who were on follow-up. And 2 weeks before they would come to us physically, a trained nurse would give them a call and have a telephonic interview conducted with predefined questionnaire to estimate their disease status. Thereafter, they would come to us, and a trained head neck surgeon, of course, blinded to this questionnaire, would examine them. And then we looked at the sensitivity, specificity, and compared them with the clinical evaluation. So we found that amongst those 400 patients, 5% had a recurrence. And going by the Tele questionnaire, 90% sensitivity was there and a negative predictive value of 99.3%. That means 72% of those patients we could avoid coming to the clinic. And when we asked the patients, was this good enough for you? 31% said that they would prefer such a follow-up. So what this proved was that symptom-based tele questionnaire has good sensitivity and negative predictive value, and it can actually reduce the pressure on the inadequate number of specialists available in our country. So that brings us to telemedicine. In India, we talk of telemedicine and then we, in the same breath, say, really, are we actually geared to do this? But remember that India has leapfrogged in technology. Telecom has reached the most rural part of the country, and healthcare needs to piggyback on this. We need to use technology to increase cancer awareness, gain the confidence of the people, and increase awareness of cancer care facilities in their vicinity. People are not aware of who's there in their region who can provide the same quality of care. So Corona actually brought this into spotlight, and then we realized that we had so much of information already, and this is what was required to actually treat cancer as well. So going forward, we realize that teleconsultation might be the new normal. It will reduce the travel, it reduces the waiting period, it can have early detection of cancer, and the patients will be comforted to know that they are in communication with a physician. A lot of centers have started this teleconsultation clinics. I was instrumental in developing one teleconsultation clinic in the remote parts of northern Bengal. So there was a Darjeeling Oncology Trust which asked whether we would provide the services to the people in the rural areas. And to our surprise, they were able to gather together a group of people, and all the people who were in remote areas of Siliguri and North Bengal were able to connect, and we were able to talk to them and provide them some succor. So actually, COVID times has also helped us. We have realized that patients who cannot travel due to travel restrictions, patients fearing to coming to hospitals which due to COVID, and also poor health infrastructure in the periphery and lack of trained manpower disrupts the cancer care. But with the telecom and IT, now there is no barrier to this treatment, and I'm sure this cancer care can be carried on ahead. So the need of cancer care in our country is primary prevention, early detection, and rapid treatment. We need to have regular follow-up for our second primary cancers, and not only that, we need to provide palliation and pain relief. So this requires a new mindset, and we need to adopt the technology early on in order to develop this model across in the country. What is the future of healthcare? As I see it, teleradiology has changed the way we are looking at images. No longer the patients are coming to us with films. They're coming to us with CDs. They're coming to us with pen drives. And now we have the zero footprint PACS systems. That means they really are not very heavy on the system. You can have your images being read out by a specialist across the country on the same day and giving back the report. Telepathology. It's so amazing that the slide scanners today can scan at 10x to 100x, and that image file can be transferred across the bandwidths which are in exceeding 1 Gbps. This technology, you can have one scanner in a remote location and one scanner in a tertiary center. And through the backbone of the knowledge network, you would be able to, communicate. Now we have got 8 centers of Tata Hospital across the country. The Tata Memorial Center has now locations in Sangrur, in Varanasi, in Guwahati, in Vizag, apart from Tata Hospital in Mumbai and in Kharghar. What is striking is that with the slide scanner in Sangrur, we are able to see the slides here in Tata Hospital. Our pathologists can actually give opinion on all the slides at various magnification. And this is a reality. Of course, teleconsultation has expanded with WhatsApp, Zoom, WebEx. We are sitting in our own comforts and we are able to communicate. Last weekend, we had a national meeting which was attended by over 1,100 people. They were paid registrations. So Tata Hospital OncoSearch, which is a very popular live surgical meeting, this year was virtual, and we were able to transmit all these surgeries over 3 days to a large audience across the country and globally. So I think this is the future of healthcare. We need to adopt to new technologies, and at times I'm glad we had something like a pandemic to actually show us the possibilities ahead. So I feel that this is what the COVID has impacted on our cancer treatment, and it has also shown us a path ahead. I thank you for the patient listening, and I'll be happy to answer any questions.
Thank you, Dr. Prathemesh, sir. It was indeed a very nice and very crystal clear presentation. I understand it was really a Herculean task for you to manage this oncology during this COVID pandemic, which is a very important specialty which cannot be postponed at all, similar to our obstetrics. Patients are also immunocompromised. That is also we should have in mind. Especially head and neck cancer, because the ENT people, they all are as such more susceptible in this COVID, the ENT physicians, everyone. Also, I was surprised to see your results of the study where you have done a study on recurrence using a study with a telemedicine, where it has given very less negative thing. It was really appreciable, sir. And a virtual tumor board, that was also a good concept. And thanks to the information technology in India, we were able to have this healthcare facilities all over. I don't know if this information technology we don't have, how we would have managed this pandemic. It is really a very big question. Thank you once again, sir. And we have a few questions for you to take. I have a question from Dr. Butt. Did you observe high risk of infection among the cancer patients?
So, as I said earlier on in our center, till mid of April, we didn't have any testing available in the hospital. So we were dependent on the testings that people started getting from outside. So we were lucky, as you can see from our surgical data, only 6 out of those 520 patients actually were detected to be positive. So we believe that symptoms are very important, and we need to take, of course, we need to take all the precautions as well. So what we were doing was the patients who were coming in for surgery, we would admit them 2 days prior. We would advise them that 1 week or 2 weeks before they come in for surgery, they should remain indoors so that they don't come in contact with anybody. So this is also a good way in order to prevent the transmission of COVID. So we really didn't see much higher incidence of infection amongst the cancer patients, as was portrayed in literature. But yes, after the patients were being treated, we would advise them not to go in community and crowded places, observe social distancing, and possibly this awareness that every patient was given at the hospital whilst he is receiving treatment and before he is getting discharged. I think that went a long way in reducing the infection rates.
Thank you, sir. I have one more question from Dr. Jaita. Do you feel that telemedicine ENT could bypass the problem of physical examination? Whether it will be sensitive enough to make and specific enough to make a provisional diagnosis based on just the history, which you can observe by telemedicine?
No, I don't think that it can do a physical examination or it will replace the physical examination. But what it does is that the patients who have been actually treated, we have a standard diagnosis of what the patient had. And then a directed questionnaire to them based on those symptoms, we can actually detect a recurrence. But to diagnose a cancer upfront, you would have to have a proper questionnaire made. Oral cancer, yes, you can detect the changes because what we also had in the past few years is the patients being given, the healthcare workers being given a mobile, which they would shine and the light and look into the oral cavity, and that those images were sent to an expert. So we know that almost 60% of those patients who were having some suspect lesions were then physically evaluated, were translated into about 2% or 3% of them having cancer. So the detection rate goes up when you are actually examining the suspect patient. So it is important that the telemedicine will give you a high index of suspicion, higher index of suspicion than not having any visual image at all.
Thank you, sir. I think that as the question has been answered. Yeah, I have one more last question from Dr. Pradeep from Department of Pathology. Your experience or any COVID positive head and neck cancer patient and its impact on management?
Yeah, so as I said, out of the 6 patients that were COVID positive in our audit, 3 of them were head neck. So they were 2 of them were oral cancers, 1 was a thyroid cancer, and those patients went on to have a normal course. They were not symptomatic, but then because we started doing testing, those patients were tested and they were found to be having a COVID positivity. And as you are aware, a lot of these patients are asymptomatic, and we didn't need to escalate any treatment for these patients. So going ahead in the past, after the audit, when we look back, the infectivity rate had increased to about 3 to 4%, being detected to have COVID whilst they are coming in for treatment. And now it has again reduced significantly. So now we are hardly seeing 1 out of 30 patients, 1 out of 50 patients having any COVID.
Thank you, sir. Thanks once again for your splendid presentation. And I think all the queries have also been discussed. I thank the participants. I thank the chair, Dr. Madam, Dr. Professor P.F. Kotu, sir, Dr. Vishnubhat, sir, and other HODs and different faculty members all across the nation for attending this webinar. Thank you once again. Our subsequent 2 weeks we will not be having the webinar in view of Christmas and New Year.
Thank you very much.
So we'll be having after 2 weeks. We'll meet you once again after 2 weeks. Here I'd like to end the session here with a very nice session we had today. Thank you everyone once again. Logging off, Dr. Deepa, Member Secretary Scientific, AVMCH. Thank you.
Thank you, Prathemesh.
Thank you.
Bye. Bye.
Thank you, sir.
Thank you.